Welcome back to the most audacious EMS podcast on planet Earth, the Paramedic AF Show. We're here to challenge, encourage, and sometimes hurt your feelings. This isn't for the weak, the woke, or the apathetic. This is a show for the ones who show up and give a damn, the bold and the brazen. So stand up, stay vigilant, and enjoy the show. Debating how I want to do it. We don't have like a set intro anymore. We're like, hey guys, what's up?
You can still do an oldie but a goodie.
And welcome to the Paramedic AF Show.
You laugh, but I mean it worked for 8 months.
Going back and listening to the time you like imitated me doing it was pretty fucking funny. You're like, and welcome to the Paramedic AF Show.
I'm so glad you couldn't see my face on that one.
Hey guys, what's up? I'm thinking about it now, so it's fucking with my head.
It's fine. We're on. We're live. We're doing another
I
episode.
know. Fuck. It feels like it's been a long week.
I mean, it has. And then I get to work for the next 3 days. So it's long in general.
All that, try to have a normal schedule, work-life balance stuff we talk about, and we end up with weekends like this where we're all fucked up.
Well, this past week was just weird anyways with my, last week at the college and stuff. So,
yeah. It's been emotional.
Yes.
We had some interesting interactions on TikTok with people this week, and one guy, we were talking about some content he was putting out, and he wanted to share a video with us, he and I were talking, like, he's like, hey, can I just send it to the EMS 2.0 page? So I get logged into the messenger because I don't usually check it a whole lot, and I realized that we had a long message from him from about 3.5, 4 weeks ago. Maybe not quite that long, but it was a little while ago. That totally missed. So I already apologized to him, but I said we'd read it on here and talk about it because it's really good.
Mm-hmm.
He's been in EMS about as long as I have. He was in the fire department first, so he had a little bit of that time in there, but he's been in EMS for 12 years. So anyway, I was going to read off what he has. Having a conversation amongst coworkers and a student this morning, something that I think is one of the biggest problems with EMS is that we, as providers, don't believe in what we're doing anymore. We've allowed ourselves to become disenchanted by the mundane things on the job, the 3 a.m. lift assists because someone's grandma fell down and needs help, for example. Is it a medical emergency? Most of the time, in our eyes, probably not. But the point is, people call because we are there. That's not something to be taken lightly, because that's why they call when they're having a true medical emergency, because we're there. We've allowed ourselves to be content with the bare minimum and floating under the radar. Never advancing, never learning new things, never stepping outside our comfort zone to apply what we have learned and acquire things to apply to our base knowledge to do more for the patients in our care. If we stay at where we've always been, do we really believe in what we're doing anymore? We've become disenchanted by the low pay scale because we feel like we're worth more. My question then becomes, are you doing anything worthy of being paid more? Or are you one of the stagnant that chooses to sit on your hands and complain instead of seeking out the knowledge and advancing yourself beyond what you were taught in class? Are you willing to go the extra mile for your patients, or are you just filling a seat and going through the motions? My point is that if we don't believe in what we're doing, who else will? Who else is going to give a rat's ass about what we do and see us as the healthcare providers we are? If we don't believe in what we're doing, then how can we ever expect to be held in any higher regard than we are right now? How can we ever expect the job to advance to a level that we would like? Lastly, how can we ever expect to be paid to our expectations when we don't even live up to those expectations? I guess I'm in the minority here. I still love this job just like I did when I started. I still show up to work every day, give 100%, not because I deserve something, but because they, the patients, do. They deserve my best and your best 100% of the time. We have to do better if we want better. Simple as that. Thanks for coming to my TED Talk. You're contemplating.
I have a lot.
Go for it.
Of fucking talks. So, I mean, I almost need to go paragraph by paragraph.
That's fine. You can chew on it for a little bit.
Do we get disenchanted? Yes. And I feel like part of it is because whether it was after COVID, the uptake in Medicaid, Medicare recipients, I think part of the problem with the mundane, like basically stupid calls, is they happen statistically so much more than the bad calls where we actually get to do medicine.
Yeah.
And part of it is like with homeless people, for example. Some of them, most of them, do not care, don't want to get better, but also all of the resources that are out there, not everybody knows about them.
True.
So, social work sucks.
Yeah.
No offense.
I'm sure most people that work in social work would agree with us.
Well, and that, my best friend works in social work, and it's a management, government-run agency problem. Not even necessarily that, like, these social workers don't care. Just, there's a lot of problems, and that's a whole other discussion on its own.
Well, it's probably like EMS where people get into it caring, and then their ability to fully act on that gets hampered in a lot of ways. And so they become disillusioned and frustrated. And
I think she would probably agree with that. I mean, that's how she feels at her current government-run job.
Because the government always makes everything better.
So sketchy, just bad things. Anyways, but because I hear a lot of this in the ER doing hospital clinicals with nursing staff as well. And part of the problem is the general populace, you could argue, is ignorant, don't care, whatever. But a lot of them don't know what urgent cares can and can't do. Just like a lot of people don't know that ERs don't all have the same ability. So they're not choosing their, I guess you could say, their care appropriately. People are calling 911 thinking, oh, even though I'm ambulatory on scene, I would feel more comfortable if somebody watched me in case something bad happens. I feel like some of it is kind of a comfort.
Yeah.
But being disenchanted, like, do I get burned out with, the lift assist or the toe pains at 2:00 in the morning? Like, especially if it's a young person that, like, it's absolute bullshit. Yes. Grandma, getting old is scary. Knowing that you could fall over and bump your head and get a brain bleed is fucking scary. So, like, those I don't so much mind. The toe pains, the, like, the 20-year-olds, yes. I think what keeps me from getting what?
Just the epitome of bullshit was I loved this. It was a 22-year-old who called at 2:00 in the morning because he had a rash on his balls. That's why he called 911 and like insisted on being transported. Mind you, this dude was like built.
Go see your PCP for your STD and don't bring it here.
Don't put on a show for your girlfriend. Like, oh, because she was there. Like, it's like, don't put on a show for her. Like, just go get it handled. Don't involve us.
If you want to hide an affair, calling 911 and pulling some scandalous shit is one way to try to avoid the inevitable.
Yeah.
But with the whole being disenchanted, I feel like the statistic of having a legit bad call that you could do medicine on is significantly lower than the bullshit. What keeps me from being disenchanted, at least me personally, I do lots of medicine and I like doing it. Like, yes, I care about my patients, don't get me wrong, but my love is emergency medicine.
Yeah.
I mean, what do you think about the first paragraph?
I can relate to it because I think for me, like, I like feeling like I'm useful as a medic. And it's not even just that it's, oh, this is, this isn't life threatening. It, shouldn't be my problem. Like, no, I mean, I'm fine going and getting grandma up off the floor at 2:00 in the morning. Like, I'm fine with that. I will honey baby deer my way through that entire fucking call. And she'll probably invite me over for Thanksgiving dinner afterwards. Like, I'm good with that. It's the ones where I understand that there's folks who are genuinely ignorant, and I don't mean that in a condescending way. Like, they don't know medicine. They don't understand medicine. It's something I think we take for granted, how we just absorb our knowledge of medicine into our daily life and can think through things that most people are like, what? So like I get that. But it's the people that aren't willing to think. There's folks that are just ignorant, and when you educate them and saying, hey, like, this is what's causing this, this is what's going on, when it's obviously something that you can point to and say, hey, that's what's causing this. What?
I'm sorry.
Oh God.
You're talking about ignorant people, and it made me think of the fact that there is a large percent of the population that thinks the pee hole and the vagina are the same hole. I'm sorry.
The more you know.
Sorry.
But so it's not the folk. There's the people that when they're scared and they're saying, hey, I don't understand what's going on. This bothers me. I don't know what this could escalate into. We know, hey, this is normal. It's fine. The list of things that could kill you that starts like this is pretty fucking small.
Mm-hmm.
So I think we've lost the ability to compassionately educate people. But to weave back to the answer, I think it's the calls that they know better, and that they're trying to get out of work. They're trying to make a scene with family. They're trying to fill in the blank. And people could be like, well, oh, how do you really know? You know. You do this enough, like.
Well, and something that I think we kind of take for granted, because, like, how many times when we go to a call, do we think twice about just walking into some stranger's house?
Yeah.
I mean, we don't. Could you imagine if just we go in our POV and, like, respond to a call? Like, not like some of the volunteer firefighters that, like, respond to calls, but us, not in uniform, not wearing anything that says fire, EMS, law enforcement, and just go up to some random person's house, knock, and say, "Can I come in?"
Yeah.
Those people are going to probably meet you with a shotgun and be like, "What the fuck do you want?"
Yeah.
Not, whether it's a good day, bad day, families wanting us to check on the patient, whoever called. The fact that we're just, like, openly invited into, $1 billion homes, or, the teeny tiny crack shack.
Yeah. Well, and I think another thing that really grates my gears is folks who feel like they're entitled. It's like, oh, well, I'm having the situation, so you're going to do what I say.
Oh, the patients?
Yes.
Oh, I
yes,
thought
the
you meant
patients.
the providers. I'm like,
oh, well, that's a whole other conversation. But no, like when patients treat you like you're a servant, like they're your master. That grates against me so hard. So
demanding pain meds.
So I wholeheartedly agree with what he's saying. Is that what he's saying ultimately between the lines here is we internalize the stuff. We internalize the stuff that irritates us, and we allow it to live rent free in our head and break down our willingness to care and be professional. So that I agree with. I would say there's more nuance. Funny how we keep using that word lately. There's more nuance to it than that. But no, I agree that we've gotten to the point where we've become jaded, not in a good way. I think there's a good and a bad way to be jaded, honestly.
Yeah. Well, so I guess you could say when talking about pay, we've unpacked it a lot. We periodically talk about it. There was a TikTok video recently that I shared. If you look up the scope of practice for an EMT, it is very similar to an LPN. And then if you look at the scope of practice to a paramedic, we are at, if not just above, an RN. So when it comes to, we aren't making what is his wording? My question then becomes, are you doing anything worthy of being paid more? Well, in theory, at baseline, yes. Our straight scope of practice, yes. However, I can appreciate what he's saying, that so many people just come to the job, do it, it's mind-numbing, they do the bare minimum, they don't continue taking classes, advancing their skills. So are you worthy of making, in theory, more money from that side of things? Absolutely the fuck not. Now, however, there are some providers, some services that are demanding is probably not the right word, but I mean, it almost kind of demanding a wider scope of practice, doing more, having more skills, having more meds, allowing paramedics to do fentanyl drips administration on. Much. I love fentanyl drips. Love it so much. Calculation, using the pump, all of the things, but it allows us to do more that is in our scope. Yeah. But The problem is we don't have the support of the federal government like we should. Now,
Yeah.
I know they're, what is the NHTSA? I think is what you said it was called.
National Highway Traffic
Yeah,
and
yeah,
Safety
but you pronounced
Association.
it as
I think that's
you
right.
pronounced it as NHTSA.
NHTSA, yeah.
NHTSA. So we do have a few federal government like agencies that are supposed to take care of EMS, and obviously, they're not doing what they're supposed to,
No.
because those agencies are supposed to be doing for us what the federal agencies did for nursing, which is lobbying, which is asking for more education funds, to help pay for school, so school is free and accessible for all, not just at community college, but as a whole,
Mhm.
helping with training and advancements and research. And we just don't have that support. Until we have that support, it doesn't matter. There's always going to be a pay cap. There was a place that we
Mhm.
worked that there was a pay cap, and there was several paramedics that were going through their critical care class, and when they were told that they would get their critical care, which has significantly bigger scope of practice, more meds, all of the things,
Expectations are much higher.
significantly, especially because they have the option to go be ECMO techs and everything. And then they were told they were only going to get 60 cents more per hour because they were at the ceiling of the pay cap. And it turned out to be, that's like way, way unfair that
Mhm.
you're going to double, if not
Yeah.
triple, my responsibility, and you're giving me 60 cents. So even the people that go above and beyond, I have all of my instructor certs. I'm not getting paid anymore for that, because there's no, I guess you could argue if I was a training officer, I might be making more per year. But like as a whole, they don't, without the support of the federal government and everything else, we're not going to get paid what we deserve, because we're not even making it baseline what we deserve for barely doing our jobs. We should be making closer to LPNs and nurses.
Yeah. I think too there's an element of it that isn't, it's not even so much just that you add more accolades to your name, because I mean that plays a part of it. If you go get the extra degrees, the extra certifications that are job relevant, then yes, you should be compensated for that. But I mean, even think about like salesmen. All
Mhm.
right, if you have a salesman who's continually putting out quality numbers and exceeding goals and exceeding expectations, he's not doing anything like different or
Mhm.
special per se. He's doing his job consistently and well, and he's dependable for that. I feel like in EMS we aren't consistent,
Mhm.
generally speaking. We're not. We in our employers don't, not all of them, but a lot of employers don't reward for it. They only reward, oh yeah, well everybody's getting a cost of living raise, or oh yeah, you checked like 3 boxes and cool, you get this little pay raise.
Well,
There's no reward for consistency.
the cost of living pay raise that
It's a
still
joke.
doesn't meet the cost of living.
No.
Well, and there are some services that do like employee of the month, employee of the quarter, employee of the year,
Yeah.
the high five award. But my personal experience at two different services at minimum is it's very clicky.
Oh
It's
yeah.
it's a
Oh
it's a
yeah.
popularity contest. So like even the
Yeah.
people that are doing above and beyond at their jobs, 9 times out of 10 don't actually get recognized.
Yeah.
It's a personality contest, and it's like, if you're not a yes person, 9 times out of 10, you're probably not going to get picked.
Yeah.
So we do need to do more. No, there's not an incentive to do better, but there are people that do put their best foot forward to advance their career, advance their skills, and they're still not getting recognition.
Mhm.
So all the way around, it needs to be corrected. Now, I think at minimum, at least especially for paramedic, it needs to be a degree. Certifications, obviously you get certified.
We're working on it becoming a thing of the
But-
past where it's just certs.
Yeah, just certs for paramedic.
Not condescending the folks that are certification providers.
Mhm.
Like how you provide care is ultimate standard for the quality of provider that you are.
Yes, but
Period.
following like the way the nurses were
Hmm.
able to justify their pay, they literally started as non-degreed, even non-certified, like, you know, providers.
Hmm.
They became certified providers, and then they stair step to, an associate's degree, and now a lot of places require a bachelor's. Most other countries, if you're going to be a paramedic, require a bachelor's. So, no, and the only way to do it would be like, hey, everybody who, is under like 10 years provider, you have 5 years to finish your associate's degree. They're going to have to do some kind of like grandfathering in and having a year cap. But until we start moving in that direction, there's not going to be much incentive. So, like,
Yeah.
I would like to argue that there are plenty of people that are wanting to advance themselves. But even then, at minimum, we're not getting paid what we're worth.
Yeah. And I like how he kind of wraps up with, if you don't even believe in what we're doing anymore, and
Mhm.
you're not willing to live up to the expectations that you set for everybody else around you, then why are you here?
Mhm.
You're just dragging down everybody around you. There have actually been some studies, and I need to go. I've heard these on several occasions, but I need to actually go track down the numbers. But if you are literally physically working in the same space as somebody who is a higher performer than you, who has a more positive outlook on life, is more naturally reinforcing and uplifting, you have, and again, I'm just ballparking, I need to go look up these numbers, but you have about like a 25% chance of your productivity, your job performance increasing.
Mhm.
If you're around someone who's negative, demeaning, condescending, lazy, all of it, you are 40% likely to be influenced by them in your work.
We
So,
rub off on each other.
exactly, and not in the fun way.
Right. Well, and I do have to say, again, we'll have to verify the numbers, but this is also, no, this is not a relationship podcast, but statistically, this is also true in relationships. If you and your partner, whether it's a good or bad relationship, of course there's tons of outliers with psych. But for example, if Daniel and I go hang out with a couple that actively fights, actively demeans each other, all the rest of it, and we start to get like pulled into their drama and everything, we're at greater risk to start mimicking those behaviors
Yeah.
versus if we hang out with people that want to be entrepreneurs,
Hmm.
talk well to each other, have good communication, don't yell,
Hmm.
we're more likely to understand and have like, me to the female, Daniel to the dude, and be like, yo, how do you make this work? And if you're able to talk about resources like we have openly said, everybody, relationship, work, whatever, need to go read the book, The Four Agreements, because it's applicable to relationships, etc. So if you're sharing resources, work or relationship wise, you're more likely to get better.
Hmm. You are the sum of the 5 people you spend the most time around.
Hmm.
So the question is, are you choosing people, coworkers, partners, friends
Hmm.
that are where you want to be, or at least further along the way of where you want to be? And are you trying to not be the person that brings them down? So,
Some people might need to be on your chopping block.
but the funny thing is, with people like that, when you start putting positive energy, I don't mean that in, the hippy dippy way. I'm saying like when you are actively putting intentionality and thought into how you live your life, how you do your work, and bettering yourself, and you're just completely focused on that, those people will drop off. You don't have to push them away 9 times out of 10. There's a couple leeches, but
Well, and um what we've seen personally is when you lose those friendships, whether big blow up or, they just kind of fade away, the loss of that person usually doesn't negatively affect you. As soon
mm-mm,
as that person, people, whoever are gone, you realize you're like, "Oh my god,
I can breathe.
I felt so heavy when they were around. Like I thought we enjoyed our time together, but
Hmm.
like there was always complaining. There was always or whatever it was.
Yeah.
You suddenly realize, "Oh my god, the air felt heavy when they were around. I was
Hmm.
just so caught up in it, I didn't realize it." So 9 times out of 10, the people that shouldn't be in your life when they leave, it's not Like, you may be sad because you're like, oh, well, they are a good people,
Mm-hmm.
just not like,
They're energy vampires.
well, yeah, which we've talked about before. So bring people around you that believe in what they do, what you do,
Mm-hmm.
about bettering yourself. Because the people that don't want to get better will usually be asshats about you doing better. You know, what's the point? It's never going to get better.
Mm-hmm.
It's because of you that things aren't going to get better because
Yeah.
you're going to keep dragging everybody
Yeah.
down. But to you, the guy, we don't.
Jeff.
Oh, I wasn't.
I was gonna say his first name. No, I mean he's all over TikTok and shit. He identifies his first name.
Oh, okay, Jeff. My name is Jeff.
I did that to him. I straight up did that to him.
Oh
like
my God.
we exchanged numbers and we're texting and he like, said, "Oh, hey, this is Jeff." And I found that GIF as fast as I could and was like, "My name's Jeff."
That's funny.
He was like, "Yeah, I've had that before."
That's funny. Well, if you're in the if you are in the minority, I guess we're here with you, and the minority is growing because there definitely needs to be an improvement.
Well, and with what he's pushing for here, and he and I have talked a lot over the last 2 days, we need to all start being more vocal about this. Like, it's so easy for us to self-isolate and think that, I'm the only one that this ever happens to, which can unfortunately turn into playing a victim card, saying, "Oh, boo-hoo, poor me. I can't help the fact that, all these people around me are like this, so I'm just, never going to be able to deal with it. I'm never going to be able to..." No.
I
Stop
think, well, and that's the thing with the podcast is we're just wanting to get people to talk
Mhm.
and start making changes. And I think one of my favorite feedbacks that we still got or have gotten to this day, God, words are hard.
It's been a long week.
I honestly can't remember which podcast it was, but it's on YouTube. Somebody, I think it was a female, had commented something along the lines of, now I'm paraphrasing, something along the lines of, "Oh my God, I didn't realize I was doing half of this.
Mm-hmm.
Thanks for bringing it to my attention." And it's not like we called her by name and said, "Oh, you're such a bitch
No.
and you did this and this." It's like we're just generally talking like, hey, most of us, including Daniel and I, have been, guilty of doing XYZ, whatever, at some point.
Mm-hmm.
We need to talk about it. Now, the pay and everything is going to be significantly more like everybody needs to, get together and go after the federal government. No, I'm not encouraging violence. I just mean
No.
written, verbal, whatever. Talk to your state representatives. But how we treat patients and each other is something we need to be vocal about and start correcting, especially with advancements in education.
And those of you who are feeling beat down for trying to advocate for a higher standard, for setting greater expectations and actually following through with them, you're not alone. You're not alone. We're all out here. We all see the same problems, and we need to start hearing each other and talking and being the squeaky wheel against this stuff, whether it's abusive coworkers, whether it's poor leadership, whether it's, subpar QA standards, whatever it is. We all need to be banding together over this because it does fall on us. It falls on you and I's generation of paramedics.
Mm-hmm.
It falls on all of us to fix this because the previous generation, sorry, y'all had your time and we appreciate what you did, but we need to change some things in a major way or we're not going to make it.
Mm-hmm.
It's not gonna happen. Go look up our friend here. His handle on TikTok is Redbeard the Medic, all one word, all lowercase. Go give the man a follow. He's trying to pump out some content now too, and he's very, very, very much on board with what we're doing and the message. Not like we're trying to build a cult following or any bullshit like that. Just we all got to stick together.
Well, and I do want to preface there are a ton of good EMS providers that are putting out information and starting talks and everything. A lot of what we've seen from other podcast providers, all the rest of it, is more like education based. We obviously talk medicine, like teaching, we'll talk about various things off and on. But I think a huge niche that isn't being discussed that we are kind of hitting on along with Jeff is more the culture side, the unwritten protocols and policies and shit that we've talked about previously. That kind of stuff needs to start getting hit harder because, there's always going to be people wanting to educate, and we need more educators.
Yeah.
But we need more people talking about the culture problem, the psych problem, the mental health stuff. Like, we need more people hitting that.
And for the people who are going to comment and be like, "Oh, well, it's useless. It's not worth it. I just give up. I just show up and do my stuff and go home." Like,
you're the problem.
you're part of the problem.
Get out.
Like, this is not what we're pushing for. Is not let's everybody hold hands and be happy. Nope. You need to either if you're not with us, you need to step out of the way.
We're not singing Kumbaya at night.
No. So we want everybody on board. I would love it if everybody got on board with making positive change for EMS in the culture of EMS. But if you ain't for it, bye-bye. Carry on. Like, if you're not going to contribute and you're just going to be stagnant and play the victim and boo-hoo, woe is me, and cry and bitch about everything without doing anything, don't care. Don't come to cry me about it.
So welcome to our TED Talk. That was our that was our TED Talk in response to his TED Talk.
So go ahead.
The second half of what we wanted to talk about today, it kind of goes along with what we talked about in the last episode. It's not like a part 1, part 2, but it all was just way too much to put into one episode. Yeah. So we want to talk about, should everyone be transported? We talked about waivers. Should everybody be transported?
And again, we have to throw in the caveat: follow your local policies, protocols, and procedures. We're not your bosses. We're not attorneys. We're just speaking our opinions on this, and you can take from it what you will and try to affect whatever change that you want to about it. A drum that I have heard beat for years is the whole, well, if they think it's an emergency, that's how you need to treat it. Bullshit.
Yeah, I was about to say, if we elevate people like that, it's just positively reinforcing
Delulu.
Yes. It's okay to have a conversation with a patient, especially when getting medical history, to distinguish the difference between a general medical complaint and then an actual emergency. My favorite question, not in a condescending way, but asking a patient, if they've had, shortness of breath, abdominal pain, whatever, for, longer than an unreasonable amount of time for it to be an emergency, a day, 2 days, a week, a month, whatever. Well, what changed to make you decide to call today? It's some form of fashion asking that, like the difference, to try and have that conversation with them and figure out, like, okay, you've been having abdominal pain. Did it change how it's hurting? Stuff like that. It's important to distinguish the difference, especially when transporting, because you have the chronically ill that are chronically short of breath, so it's a medical complaint, versus the ones that have silent lung sounds and need CPAP right fucking now. That's an emergency.
Yeah. And I know this is an extreme way to look at it, but really, that mentality of, if they think it's an emergency, then treat it like it's an emergency. You're literally, you're reinforcing delusion. Now, that doesn't mean that you need to be condescending. It doesn't mean you need to be a dick about it. You can tell them, hey, I hear what you're saying. Here's what I'm seeing is going on, and here's what I'm not seeing. Here's the things that aren't at play here to give you some peace of mind that you're stable, you're fine, you're doing okay.
Mm-hmm.
Giving them the courtesy of having that conversation and treating them like a human being and not treating them like an idiot. Maybe they are. Maybe they are. But you can educate them. That's okay. It would be like, if one of the kids, came up and they were trying to tell us that, the sky was purple. And it would be irresponsible of me to say, oh, wow, you know what? It really is purple today. No, because that's reinforcing something that is not factually true.
We need to tread lightly on this conversation because I just went into...
Oh, I totally went a couple places.
Yeah, I went a couple different directions with that.
Yes.
Well, and when distinguishing between, like, a patient getting worked up over something that we're not, and they're, like, constantly, oh my God, I'm so scared, I'm so worried, blah, blah, blah.
Mm-hmm.
My favorite thing to usually tell people is, your vitals are good, here's what I'm seeing, but listen, sweetheart, I'm not worried. Mm-hmm. If I get worried, then you can get worried. And 9 times out of 10, 99%, whatever, pick a high number. even on the really bad calls, I'm usually still pretty fucking calm.
Yeah.
Because
Yeah.
if you start to get worked up, they're going to get worked up, which is probably going to make the anxiety make everything else worse, regardless of what the complaint is. So usually I tell them, I'm not worried. When I'm worried, you can worry. And that will help kind of taper their anxiety about whatever it is that's going on.
You need to position yourself as the emotional mirror in the room.
Mm-hmm.
And people are going to bounce off of what you're doing. If you are presenting yourself as confident and secure, they're eventually going to feed off of that. Are there exceptions? Yes.
I mean, always.
Yes, there always are. But you can because a lot of times their complaints are very anxiety driven, or they're worsened by anxiety. So how you talk to them is going to dramatically impact their mental health through this. And hey, guess what? They may say, you know what? I'm really not worried about it. I think I'm just going to stay here. I'll if it gets worse, I'll call back. Cool.
Well, and that's a conversation I never talk people out of going to the hospital.
No.
However, my favorite thing to do, can't really say favorite, but something that I commonly do is if I know a patient's complaint is bullshit and they are, on the fence about going, we haven't made a transport decision yet, all the rest of it, I let them know. Your vital signs are good.
Mhm.
I have done everything that I possibly can.
Mhm.
In your condition right now, the ball is in your court to decide what you want to do. I can take you to the hospital. Your family can take you. You can go to urgent care, whatever the daytime is. You can make a primary care doctor appointment, but ultimately it's your decision. And a lot of times those patients will decide to go either POV or urgent care or their PCP if you explain kind of what they need. Now, there have been times where a patient has asked me, can I go to urgent care for this? And I can tell you right now that that the patient would need, this and blood work and all the rest of it. I'm like, this urgent care system that's in our area, is not going to be able to do X, Y, Z, this, I wouldn't go to urgent care, this. That's why we as providers need to be knowledgeable with what facilities can do what.
And I don't know if you've noticed this, because I still see it periodically. There are hospital systems that will post billboards and say, hey, this is a complaint that's appropriate for your doctor in urgent care. This is an issue that's appropriate for a hospital.
I see it circulating on even social media. There was one that it was around a holiday. It might have been the 4th of July. It might have been 4th of July because, so many firework accidents and everything.
Oh, yeah.
They'll circulate those charts. I've seen TikToks about them. My favorite is like the OB ones where doctors will be like, is this, a OB appointment, like doctor's office, or should you go to the L&D for an assessment?
Well, I guess like my thought with this is if the hospital is expecting that someone who's not medically trained can make a self-assessment to say this is not appropriate for me to go to the emergency room, they're putting those billboards out there, and their legal teams are on board with this. They're putting those billboards out there for the everyday person to make a self-assessment and a decision about whether or not to go to the emergency room. And yet we, the medically trained people, are being cut off at the knee saying that we can't do that. Now, there's my big caveat to this is there's a lot of lazy motherfuckers who have made it so that we're in that position. We are in that position where we can't say those things to patients because there's a lot of motherfuckers that have talked people out of going to the hospital that shouldn't have. And I listen to some of them do it because they'll sometimes say even some of the same words like what you're saying, but their tone is very much, oh yeah, you can, you can go to the hospital if you want, but it's that like you're an idiot if you do is what they're implying, and what they're saying between the lines. I'm not saying you do that. I'm saying
shit, I don't do that. But
No.
I know what you're talking about, though.
That's just as shameful.
Well, and that's where we come back to. It's not necessarily what you say, it's how you say it. The only thing that I have to say about that right there, though, which I do completely agree with what you're saying. The way I think a lot of places, people, etc., get around it is, one, I guarantee you those billboards, in particular probably has some fine ass print that you can't see that says, but when in doubt, go to the hospital, or, this is not medical advice, blah, blah, blah. Because if you pay attention, the conditions that are listed on those things are usually extremely vague. Like, chest pain, go to the ER. Okay. Well, we know what kind of chest pain, because you can have
Yeah.
this chest pain and that chest pain. And, I just got punched in the chest. Well, that's chest pain. That doesn't need to go to the hospital.
Yeah. Yeah.
Unless it's respiratory involved, which there are so many gray areas to it. So I feel like with us, something that we often hear is, oh, well, it's a liability because unless you can run that patient's, blood work, you can't know.
Yes. And which I hold to often, if there is
Agreed.
more complex medical complaints, hey, I can't make a decision for you. I can tell you what I see right now.
I'm talking about
But
like even being able to waiver the bullshit.
yeah. Well, and I think, because we love to beat the drum of abuse of 911.
Mhm.
We love, 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 love to play that song over and over and over again. And yes, there's a lot of abuse that we can't control. I can't control how many people pick up the phone and call 911. Can't do it.
Or the frequent flyers.
The frequent flyers, all of it. However, we can take some steps to mitigate that. And this is not stuff that's abnormal. This is stuff that's done in other countries or even in our own country of, and we've even piloted some programs around here of diverting people from the emergency room that legitimately don't need to be there. But I think our first steps to getting to that are, one, we need to set a standard that all providers are held to when it comes to evaluating patients and triaging patients appropriately. And there needs to be a zero tolerance policy for laziness there. 110%. I'm not advocating micromanaging because that doesn't help anything either. But you have to have some accountability for this. You have to have some rigorous accountability for people being lazy and triaging patients. Number one.
It's funny. I'm pretty sure we made an episode
I
called
think we
Rigorous
did.
Accountability. And I think we even had another episode that talked about it in a different way.
Yeah. Shocker.
Go back and listen.
Yes, that one, the rigorous accountability one, is on YouTube as well. It's one of the older throwback episodes, so it's just listening to us and some cool AI graphics, but we do talk about that just a little bit. But
we share stories. It's entertaining.
but once we have got that down pat, once we have people that are, and there's always going to be outliers that need to be dealt with, but once you get everybody on that same page, then you should create a solid diversion plan that assists non-critical and chronic patients to access medical care without having to go by ambulance. I know right before COVID hit, one of the larger hospitals in the area was actually going to partner with Lyft, because Lyft was piloting their medical Lyft program. And it was the early days of COVID that they were kind of trying it out, but I think Lyft just didn't want the liability of exposure. Other larger cities offer taxi vouchers to patients that are non-critical. There are ways to get around it if we actually try.
Well, and Medicaid, Medicare does have I think it's like a 1-800 number or something where you can call and arrange transport.
Yes.
But the problem is you have more patients and calls and appointments and et cetera, especially with the aging population, but also the number of people that are on Medicaid that don't need to be on Medicaid.
Yep.
That are overwhelming the system, so they don't have enough drivers. So that in of itself is something that government is, gonna have to help with, kick people off that don't need that type stuff. Actually start enforcing the purpose of these programs.
Yeah.
Which I know we can't control, but just be aware that it's bigger than us. We can't blame each other for everything. We can't blame the hospitals, for everything. We can't blame the patients that are chronically ill, but I'm sure there are ways, hospitals can set up their own departments that can help with transport. There's stuff that us, especially if we work for hospital-based ambulance services, could be talking about. Anybody can write a grant. Anybody can write a bill to be sent to the Congress. It's just a matter of people have to actually care to take the steps to do it.
And I mean, and we've seen an uptick, and COVID really helped a lot with this. We've seen an uptick in alternative applications of EMS
Mm-hmm.
to managing this. Something that we've seen, there's been a huge expansion of in the medical world is MIH, Mobile Integrated Health.
Mm-hmm.
Um, I got to see a lot of it piloted around here when it was starting to become a thing, and now it's a thing.
Now it's huge.
And even in adjacent counties,
Mhm.
it's becoming more and more popular. And I love it. And I know that the application of it is very limited right now, but community paramedicine specifically is wonderful. And like what one hospital system locally to us does is a lot of their community paramedics are assigned to skilled nursing facilities.
Mm-hmm.
And so they will go in there, and their goal is they actually communicate one-on-one with the doctors. So they have designated physicians for their patients at these facilities, and they are actively interacting with these docs, getting orders, doing more advanced treatments, doing everything they can to keep those patients in the facility and out of the hospital.
Mm-hmm.
Because they can do those appropriate treatments there. They can draw blood, they can do all this and do it. Now, some things they can't, and they still have to send them out. But I have had plenty of sick patients, and I know you have too, where you go out to a sniff and you get there and the community medic has been treating them for the last 2 hours
Mm-hmm.
and giving them antibiotics and fluids and additional meds and all these things and trying to manage that patient. That kind of stuff is going to go a long way moving forward to alleviating a lot of the excessive 911 call volume.
Well, because how often do we go out to these patients? They just gotten discharged from the hospital, and oh well, I can't pick up my meds and I'm short of breath. I don't have my inhaler. Well, community medics can get those meds filled,
Mhm.
can get set up delivery, can do things. And I had one. I was called out for shortness of breath. I go out, and I mean the lady was wheezing.
It'll get off of
The
there.
lady was wheezing. And initially, she was saying that, oh, I want to go to the hospital. Well, as I was talking to her, I didn't know that she was an MIH patient. And next thing I know, her assigned community medic shows up, and he's like, I'm going to take care of this. He goes, she has a CPAP. She has a breathing treatment. This is anxiety. We're going to treat. So, I mean, he asked me, he's like, are you good to stay on scene, in case whatever? I was like, yeah. And I mean, I watched him talk her through it, got her on the breathing treatment. She did use CPAP off and on during the day. So he, not forcing her to stay home. Like it was
Yeah.
all within her treatment plan. And it ended up being a waiver. Now, were we still out of service while, doing all this? Yes. But it was still shorter amount of time than if we had transported.
Mhm.
It also saves her taking an ER bill, her getting a bill,
Mhm.
us maybe not being able to, collect on that bill, me giving her medication because she used her own medication. I didn't give
Mhm.
her anything out of my bag. Oftentimes what we see is these chronically sick people, they're going back to the hospital, within 72 hours after being discharged, or they're going once a week. So the hospital's actively losing money. It's taxing the system. It's taxing the hospital. It's, why didn't you go to CVS and pick up your prescription? Oh, well, I didn't have a ride.
Yeah.
And, I'm an older person who doesn't believe in delivery. Well, they're able to help. They are a godsend, all of the gods, whatever you believe in. Now, I have heard that there are certain programs that are wanting to specialize in community paramedics. So, like, you have the general community paramedic that kind of does everything.
Mhm.
But then you have, like, diabetic in nature that literally, like, take classes to know down to, like, freaking molecule how diabetes works. And, CHF and cardiac and all this that is supposed to very specifically help these patients.
Mhm. This is the kind of thing because I think what people expect when they say, "Oh, we want more for EMS. We want to be, we want EMS to be better and be treated better." Well, this is how you do it.
Mhm.
Is you think outside the box. Community medicine, mobile integrated health is EMS thinking outside the box.
Mhm.
And we're taking our skills. Where are our skills most useful? Out of the hospital, pre-hospital.
Mhm.
So it's putting us out there. And I mean, I don't have the inclination to do community paramedicine. Maybe, I mean, I can see a version of me that would do it and would enjoy it. Where I'm at in life now, no, not really. But
Well, but let's take the guy that went through paramedic school with me. There was a, there was a guy who was a retired engineer who literally one day woke up and said, "I am bored of retirement. I'm going to go to school." He got his freaking EMT, decided he loved it, went to paramedic school at 68 years old.
mhm.
Made it through paramedic. And by the end of the program, literally his sights were on community medic. He was like, "I love this." That man knew how to fucking talk. He loves it. He loves building the relationship with the patients, the
Mhm.
providers, the doctors, all the rest of it. But he knew that at his age, with his body, all the rest of it, he couldn't do 911.
Yeah.
Now, he knew that he had to be a paramedic for so many years, so he was like, yeah, I'm going to do my years of service. And you know what? He's not there yet, but I think someone like him, the aging paramedics, maybe that
Mhm.
can't do interfacility like and are extremely knowledgeable, maybe, the EMTs, whatever, would be amazing at doing not like, oh, I want to send them off into a hole until, they retire or die, but like their personal skills would be beneficial in a role like that.
Yeah. I think another thing too, we haven't seen I haven't seen as much of this lately. I don't know if this has fizzled out or if it's just something that isn't really as feasible around here, but it's the ET3 program, and it stands for Emergency Triage, Treat, and Transport Model. Basically, what they were doing is saying, "Hey, here's some very strict criteria in evaluating a patient to see if you can transport them to an urgent care."
Mhm.
Again, it's tying up an ambulance, but when you think about the role we play in healthcare more broadly, you're taking a patient to the appropriate facility.
Mhm.
That facility just happens to not be an emergency department at a hospital.
Mhm.
So, and I don't know, and maybe that model is fizzling out, and that could be the case. But models like that have a broader look at how EMS can expand their role in healthcare and play better with the hospitals and actually be of more service to the community in an effective way. Because no, you don't need to, use a 2x6 as a fly swatter every time. Now, there's some big old bugs. Yeah, sure, you need a big old stick to beat them with. But,
Mhm.
you know, if a fly swatter works, a fly swatter works. If the urgent care is sufficient, then use the urgent care.
Mhm.
That's what they're there for. You're just a different vehicle to get them there and transfer care there. So I'm curious to see how those models grow and what kind of options like that we are able to find. I think MIH is here to stay.
Oh,
MIH is
they're
doing some cool shit.
they're actively growing. It's helping with the statistical number of patients returning, like the chronically ill,
Hmm.
especially with the aging population returning to the hospital so frequently.
Yeah, yeah.
Especially because they're really good jump up a doc's ass advocate. Don't get me
Hmm.
wrong, we are too. But I
Hmm.
mean, when you personally know a doc and
Yeah.
personally know a patient, it's a little bit easier to be like,
Well, and
do what I'm saying.
when you build the relationship with those physicians, it's a lot easier to advocate for your
And
patients.
they trust your judgment too,
Yes.
especially if you're
Yes.
committed to doing your job and do better.
Well, and I guess that's a closing pet peeve, not really pet peeve, but just thought I'll go with is I hear so many people talk about, oh, the ER just doesn't treat us with any respect. When you walk in with that chip on your shoulder,
Mm-hmm.
you're not going to act respectable, and they know.
Mm-hmm.
They see it. I can honestly say, like, I mean, yeah, there's been times I've had a little bit of a chip on my shoulder before, but I also got over it.
Mm-hmm.
And if you walk in and you speak factually, you advocate for the patient. If you don't know something, ask. If you did something wrong, admit it and don't take it personally. Guess what? You'll have a better relationship with those doctors. They'll take your report seriously. They will actually listen to you. They do.
As
They will.
Yeah, we had great experience. And I mean, there were times when I worked for one particular service, we would always go to the same hospitals. where I would walk in, the doc would look at me and be like, "Oh God, it's you again. What's going on?" Because he always knew report was accurate, and if I was taking them to that pod at that facility, it was probably a shit show.
Yeah.
And just like we can tell when we're talking amongst each other, the bullshitters, the ones that are one-uppers, haven't actually done something, they think they're more important than they actually are. If you think we can tell, the docs can tell, the nurses can tell. Even if we don't do each other's jobs, they can tell. Just like we can tell when there is, a dumb nurse or an ass nurse. We can tell across because it's still human behavior. It's still how you talk to each other.
Mm-hmm.
And if you don't want to be treated like you're stupid, first, don't be. How well, I mean, seriously, if you walk in and, with a stroke and you haven't checked a BGL and it's actually hypoglycemia, then the nurse is going to look at you and be like, and the physician is going to be like, what the actual fuck?
Or the helicopter crew will look at you that way.
Oh yeah, I mean, or the helicopter too. Now, do we make mistakes? Yes. I have to throw in that caveat. There's always exceptions to the rules, but you still need to be trying your best to do your best. And don't give them anything to actually be like, well, you're being an ass, so I'm going to treat you like an ass, even if you're being nice today.
Yeah. Anything else you want to share with class?
Go listen to our other podcasts and be better.
All right, guys. Next episode, I think we're going to do a Q&A because we actually have a lot,
yeah.
Good feedback from you guys. I love it. Go subscribe on YouTube. Go watch the podcast on YouTube. Don't just watch TikTok. We put stuff out there so that you guys will hear it.
Get a taste.
Yes, a tease. But
it's kind of like sampling of a drug. You need to come get the rest.
Yes, you need the buffet. But go follow the long form content on YouTube because you get a lot of longer conversations with more context, and I think you'll enjoy what you find. So, if you learned something, awesome. Tell your friends about it. If you were offended, good. Go tell your friends about it too. And we'll talk to you guys next time. Bye-bye.